Hi there, and thank you for joining us for Tampa General Hospital's Ask an Expert, a live Q&A series. I'm your moderator, Danielle Crousillat, joined by Dr. Daniela Crousillat, cardiologist and director of the TGH Women's Heart Program, and Maresa Glass, director of TGH Pharmacy Patient Care Services, who also had spontaneous coronary artery dissection, also known as SCAD, which we'll learn about today. And it's a type of heart attack that's more common among women and often underdiagnosed. Thank you both so much for being here today.
Thank you for having us.
Thanks for having us.
And March is also Women's History Month. So it's a great time to talk about women's heart health and specifically, just as I mentioned, SCAD. Before we begin, though, we do have a few housekeeping notes. If you have any questions, be sure to place those in the comments section, and we'll get to as many as we can as time allows. And a reminder that yes, Dr. Crousillat is a medical expert, but please make sure to always consult your primary care provider for individualized medical advice. All right, with that, let's first get started with Dr. Crousillat. Can you explain in general terms what SCAD is?
Thank you, Danielle. So SCAD stands for spontaneous coronary artery dissection. What I would say is that was probably a term that no one had really heard of, and we're hoping to really change that. Over the last decade, there's been a huge paradigm shift in just awareness and increasing recognition that there's actually different causes and etiologies of what causes a heart attack. We now know that spontaneous coronary artery dissection is one of the most common causes of a heart attack in women traditionally below the age of 50, and also in women in different stages of their life, including in pregnancy and also in perimenopause. Highlighted here is sort of a little bit of how we think SCAD is different than a quote unquote traditional heart attack. So SCAD stands for dissection, and dissection is usually a tear. We think SCAD begins from inside the coronary artery vessel wall, and there's a blood clot that is formed that then slowly that blood clot ends up sort of constricting the blood flow down that coronary artery, causing the same sort of classical symptoms we'll discuss today. Sometimes that blood clot will then go on to also cause a tear in the artery, thereby the word dissection. This is very different than sort of the traditional heart attack that we've known and sort of studied for many, many years that happens in both men and women. Those are those traditional blockages you see pictured at the bottom that usually consist of things like plaque and calcium and buildup. So we do know that not only is SCAD sort of different in terms of what's actually happening in the coronary artery vessel wall, but SCAD also tends to predominantly affect women. And we'll talk about maybe what some of those ties may be throughout the webinar today.
Great information already, Dr. Crousillat. We did have some pre-submitted questions. Lisa and Lori want to know about the symptoms and warning signs. Maresa, what were your symptoms of SCAD that prompted you to seek medical care?
Yeah, so a little bit different than maybe in what we think of as a traditional heart attack. I didn't have any symptoms leading up to the event. It happened all at once. I was sitting at my desk and started to have radiating pain between my shoulders, which was interesting. A little bit of chest pressure, but it came on all of a sudden, just out of nowhere. I had exercised earlier that morning, didn't have any symptoms while exercising. I did not have any shortness of breath, but I knew the pain was something that I needed to have looked at. It didn't feel like a typical muscle pain or pain from overexertion of a muscle. And to be honest, it really was just what we'll call women's intuition. I knew that it was something else going on. I thought it might have to do with my heart. And then I went to the emergency room just to make sure.
Good to know. It's always great to have a patient perspective, I'm sure, for our audience who's watching today. Dr. Crousillat, the SCAD symptoms, you touched on this a little bit, but I'm hoping you can expand. Are those similar to a heart attack? And are there any early signs that someone should look out for?
I think that's a great question. I just want to thank Maresa for sharing her story with us today. So this is a great question. I think there's a lot of myths out there as to like men present one way, women present the other way. What's the most common? This is a nice little infographic from the American Heart Association. What we really want to drive home is SCAD is a type of heart attack. So the heart attack symptoms that patients with SCAD present with are really no different than sort of that quote unquote traditional heart attack that we are comparing this to. So the symptoms are truly, when we look at our registries and our patient populations that suffer from SCAD, the symptoms are usually the same. So this should really be no different. What's different about SCAD is the mechanism we talked about. And it's also different because it tends to have a predilection for a different patient population, one that's typically under-recognized and underdiagnosed. The traditional woman walking in with the symptoms that Maresa described, maybe, providers and maybe even patients may not think about those signs and symptoms of being signs and symptoms of a heart attack. So a couple of things I'd love to highlight. One is woman's intuition and advocate for yourself. You know your body the best. Something feels wrong, awry, not right. You've never had symptoms like that before. It's like call a friend, tell a friend, tell somebody and maybe get it evaluated. And that's really the sort of silver lining to these stories. The second thing I would say is that men and women will both present with some degree of chest pain, pressure, discomfort. It's true that women tend to sort of they tend to report other symptoms that go with the chest pain or pressure. So they'll say, I'm short of breath, I'm fatigued, it's going funny up until my jaw, or it's going into my armpits. But at the end of the day, men and women with SCAD and with classical heart attacks will all present typically with some degree of chest pain or pressure.
Right. Good to know. We had another pre-submitted question from Brandy. She's asking, what are the triggers? Is it caused by anything?
That's really the $1 million question, and we wish we had all the answers. So, the cause of SCAD is not entirely yet known. We do know that there are some things that are associated with SCAD, and we'll talk a little bit about some of those. The difficult thing here is that SCAD is typically or sometimes can be a representation of something else. I'll give you an example. Through our research and in our registries, we're screening women for an underlying vascular disorder, meaning there's something wrong with their arteries that then predisposes them to have this tear or SCAD, as we talked about. When we screen women for that, we find that maybe up to 2/3 or maybe 15% of them have had an underlying abnormality, but that's after they present with SCAD. So as you look at sort of this little sort of circle, you'll find that we definitely have some associations, meaning we don't know the true cause of it, but we do find, for example, as I highlighted, that about 50% of women may have an underlying either arterial vessel problem or a connective tissue disorder. We're really in the infancy and early beginnings of figuring out, is there a genetic link? There is no sort of like check the box, send the SCAD test, which a lot of our women are interested in. We do know, as I discussed, it has something to do probably with hormonal fluctuations. We don't know if it's the absolute number of the hormone or if it's the hormone coming up or down or which hormone it is, but we certainly see SCAD associated with pregnancy and particularly the postpartum period in the first week. And we also see it sort of perimenopausally for women, but there's a lot of things that are still unanswered there in terms of exactly the driving factor. And then the last thing I would say is that SCAD is really something that's comprehensive, where we need to think about all of it, not just your underlying potential triggers, but the associations. Maresa mentioned she was at the gym that morning doing her regular workout, nothing new for her, but we have found that both in men and women, there is an association with things like intense, abrupt onset or new exercise. We've also found associations with things like emotional and psychosocial stressors. That doesn't necessarily mean that's the cause. So I would still say, when I'm asked, the $1 million question is there a cause? I would say it's a big question mark and it's still unknown. And we're really in sort of the beginnings and hopefully getting to the meat as to what's really the driving factor. And then not only what the driving factor is, but what are the things that may be adding to it.
Right. And I know we're going to get to some research a little later that you'll discuss with us. Looking at another pre-submitted question we had, Jennifer and Lois were asking about tests to get done and diagnosis. So first, Maresa, I'm going to go to you. Can you share what your journey has been like from diagnosis through treatment? And I understand you may have also had some rehab.
Yes. So after I knew that I needed to have an evaluation done from the emergency department, similar to what Dr. Crousillat mentioned, I did at one point feel a little silly, thinking, what am I doing here? Are they going to, tease me about coming here because I had some shoulder pain? The nurses at the ER were great, and they actually thanked me for listening to my body and coming in. They said that's always the right thing to do. So they put on some EKG monitors, checked my heart rhythms, and then drew some blood to see if I had any changes in my blood levels that would be consistent with a heart attack. And I did. I was presenting with a very typical way that a heart attack presents. And then I needed to be admitted to the hospital. So I spent a couple of days in the hospital. I did have a cardiac catheterization where they look into the arteries of the heart, and they were able to confirm that tear that we spoke about earlier. And then I think we'll talk a little bit about treatment and follow-up in a moment, but I'll help share that part of my journey as well.
Great. Thanks for sharing that, Maresa. Dr. Crousillat, going on to that question, how is SCAD typically diagnosed, and what are those treatment options once you do have a diagnosis?
So I hate that you felt silly. I know it's a webinar and there's many women joining everywhere who probably felt the same way. And that is something that we're hoping truly changes, and that we're able to move the needle. That's, a young woman walking into the emergency room, it's not a weird thing that they could potentially be having a heart attack, right? Because one of the things that we should mention is, how do you make a diagnosis? Well, the only way of really making a diagnosis is if you or someone else recognizes the symptoms and you present for potential evaluation or care. Because as you'll look at this little sort of timeline and graph, this is again no different than a traditional heart attack. If anybody else, let's say we replace that picture with a man, an older man, someone with diabetes or high blood pressure, or the other traditional risk factors for cardiac disease we think about, they would probably do the same thing: hook them up to a heart monitor, get an EKG, draw usually we call it a troponin, which is a protein and a blood marker that can be elevated when there's injury in the heart. Usually it can represent a heart attack, although there's other reasons for why that level may be elevated. And then that last little funny looking picture you see under diagnosis, as Maresa mentioned, is the classical and really true gold standard way of making the diagnosis of SCAD is by looking at the coronary arteries. And the way that we do that is through a test called the cardiac catheterization, or cardiac cath, where they go through your wrist or your groin. They spray a little bit of contrast so that it allows those nice arteries, which you see as in black in that sort of fluoroscopy picture, light up. And we can see regular blockages that way. We can see SCAD in that fashion. But the two things I really want to highlight here is, without patients and really women presenting with symptoms to even start or think about that evaluation, or without taking a woman to the cardiac cath lab, if you suspect SCAD as the diagnosis, that really kind of wipes out the patients that we may potentially be missing. And that's where that's the soapbox I stand on, which is advocate for yourself, but also in provider and cardiology in recognition, right? And looking at cardiac caths and saying, like, this doesn't look like the traditional heart attack. Could there be something else going on here? So we really, it's the full spectrum, but we have to start from the beginning. And the beginning is recognition and awareness.
Great. Thanks for those reminders. And then Maresa, for you've been diagnosed, you've started some treatments, but overall, what has it been like having SCAD and living with this?
Yeah, so there are some medications that I take to help my heart continue to function well. I was very fortunate, and I don't have any damage to my heart after the heart attack. I also participated in cardiac rehab. And so TGH has a wonderful, long-standing cardiac rehab program. And this is where I really was able to go. Again, they have you hook up to a heart monitor while they test your exercise tolerance. So I did things like ride a bike, use the elliptical, walk on a treadmill, all with increasing intensity while my heart was being monitored and my blood pressure was being monitored before, during, and after the exercise. So this gave me a lot of reassurance on what physical activity was safe for me to do, because that was my biggest question. I felt fine, but you can't see what's going on inside the heart, right? And so after my hospitalization, I was really worried about how much exercise is too much. Do I need to be resting more? And so the cardiac rehab program was really, really great for that. Dr. Crousillat mentioned emotional stressors, right? I think it's common that today we all have some emotional stressors in our life. So I do have a continued meditation and yoga practice, trying to take extra breaks throughout the day, just being a little bit more mindful of when I am undergoing some stress. I did take a decent amount of time off of work after my heart attack, again, to just decompress and focus on getting better. And as Dr. Crousillat mentioned, I did have some recommended screening for some of the other comorbid conditions or other things that might be going on in my arteries that may be related to the SCAD.
Good to know, and glad you're taking advice about checking in on yourself too. This is live, so we want to encourage questions. We've got a couple that are coming through. I know Catherine had sent in a comment just saying, "Thank you, Dr. Crousillat, for all you do to support patients and advancing research of SCAD." So shout out to you, Dr. Crousillat. We also had a question just come in now from Anna, and she's asking if SCAD could be confused with another diagnosis, like I think it's syncope. So Dr. Crousillat, I believe that one's for you. Could SCAD be confused with anything else?
Yeah, I think thank you, Anna, for that question. I think you're saying, could the symptoms of SCAD be confused with something else, such as syncope? So syncope is usually when someone loses consciousness or passes out, not a traditional way we think of presenting, but it could come along with a lay of the land of presenting with a heart attack. So definitely women who present with SCAD present with a variety of symptoms. So being on alert, both as the patient and provider, is of utmost importance. I do also want to address that sometimes the diagnosis of SCAD is also overlooked. So I think your question was mostly surrounding symptoms, but we have patients in which we sometimes look at the cardiac catheterization and the diagnosis may have been missed. That is no one trying to miss things, I assure you. It's just the fact that we, and most of us, have been trained and our eyes have been trained to look at different things when we look at these imaging studies, whether it's a CAT scan of the coronary arteries or potentially a cardiac catheterization. So it's a fair question to ask, but we want the question to be asked. You think a woman presented with a heart attack, she may have gotten a stent. Go back and take a second look. Could it have been SCAD, or do we think this is the run-of-the-mill kind of atherosclerotic, what we usually call traditional coronary artery disease causing the heart attack? Because it really does have implications of how we counsel women, the treatments that we give. So it is important to sort of make that distinction. And I tell a lot of women time and time again, the diagnosis is really important. Because I think without a diagnosis, first of all, I think it means a lot for patients, right, to know what they had, even if there's a lot of unknown, and I apologize for that. But I think it's important to know the diagnosis so you can then sort of say, how do I move forward with this? Are there any tailored treatments for it? Are there modifications? Is there a particular cardiac rehab for SCAD patients? So I love the question because there is a lot of overlap in symptoms. There are misdiagnoses, both from the symptom perspective and also the imaging studies. So I'm grateful for webinars like this to just sort of like have more women all over the world listening to and just learning about potentially a different entity, whether they have been affected by it or not. You may eventually know someone who has been affected by SCAD, or you may catch those symptoms or even tell a friend that, that's something that's under consideration. So we love anything, increasing awareness and really patient advocacy, as we're highlighting with Maresa today, is really at the forefront and really central to our work.
Thanks for answering that one. And Anna also said thank you for your answer on that. We do have just a couple minutes left, but we want to make sure to get to some other questions that came in. Dr. Crousillat, another one for you. Edith is curious about genetic links. So is SCAD genetic, and why is it more common among women? Do we know?
Oh, I could just say we don't know, but I will elaborate on that. There is no, and I think I mentioned this, like SCAD genetic test. Like, let me just send that test. Do you have it? Do you not? Oh, that's probably why you have SCAD. That really, truly doesn't exist. Now that we're sort of doing, or there has been mostly in the research side of things, more genetic testing among patients that have been diagnosed with SCAD, we're starting to see some genes that may have susceptibility. We call them kind of susceptibility genes. Like if you have that, it may increase or predispose you to have something like SCAD, but it really is in its infancy. The role of genetic testing really in women and patients who present with SCAD mostly surrounds people who we have who we have a suspicion that they potentially have another one of those sort of arteriopathies that we talked about. So for example, if you're diagnosed with things like fibromuscular dysplasia, if you have connective tissue diseases such as Marfan's or low EDs, we know that those truly do have strong genetic links. And those are patients in who we are considering or sending for genetic testing. So I would say it's sort of a work in progress. Not everyone with SCAD probably should or get sent for genetic testing. It depends if we find an underlying sort of genetic link as to potentially the cause of SCAD, as mentioned, like connective tissue disease or an arterial systemic arteriopathy. But there's definitely a lot of interest in sort of figuring out if there is a link. The second part of your question is, why is it more common in women? Right. So I think part of the genetic basis is also like, are some of those genes more commonly found in women because we have two X chromosomes, for example, and we actually do not know the answer to that. As we lightly kind of touched on, there's a mention of hormones. Like we definitely know that hormonal fluctuations in the reproductive lifespan for women obviously are different than they are in men. So are hormonal fluctuations enough to account that for that sort of disparity and difference between men and women? We know 90% of SCAD patients, when you look at our registry, are women, right? And is that enough and sufficient to explain it? And the real answer, unfortunately, is we don't know, but we are very excited and motivated to continue to uncover some of the answers to those great questions.
Thanks, Dr. Crousillat. And I know we've got a lot of comments and questions, so you might have to answer some of these after the fact, but I do want to get to a couple more that we have. Maresa, from your personal experience, what would you want people to know about SCAD, and why is it so important for you to raise awareness about the condition?
Yeah, it's really everything we've talked about. This seems to be very uncommon. The knowledge about this is uncommon, not just amongst the patients, but amongst the healthcare providers themselves. So I've really found it important to share my story, make sure that patients don't get misdiagnosed or not evaluated because they don't present with history of a typical heart attack patient. And I also think, again, just women's health in general, it's important to talk about these nuances, especially around the perimenopause and the postmenopausal stages of life, these things that we're never taught are even possible to happen. I'm definitely finding it very important to start talking about these.
Great. Thanks for sharing your part of your story, Maresa. Before we wrap up, Dr. Crousillat, wanted to ask you, how is TGH's Women's Heart Program advancing care of women with SCAD?
Thank you. I mean, honestly, we're very lucky at Tampa General here to have a dedicated women's heart program that really focuses on diagnoses that either are more common or more prevalent among women or only affect women. And SCAD has really come to the forefront of that. All the little hearts you see peppered across the US are different places that have really been recognized by SCAD to be centers of excellence where there's at least one expert that has some degree of specialty in diagnosing or caring for patients who have been affected by SCAD. What these little hearts also mean is that there's usually investigators at these sites who are really also at the forefront of pushing research forward and being a part of that. So we are really delighted to be the only heart in Florida right now, though we'd love more for collaboration. And as part of this process, we really recruit patients to be a part of the science with us so that we actually as a whole can learn from their stories. Maresa's story is one of them, but we kind of clump all of them together and we look at thousands of patients affected over the last few years. And this is how we start to really build those associations we talked about, start answering some of the questions you see in this jigsaw puzzle, which now that I look at it, looks very busy, but this jigsaw puzzle is sort of our iSCAD expert panel rendition that we published this year that basically is like, well, these are the things we think we know, but what are the gaps? And more importantly, like, how do we get there? How are we going to bridge the gaps? What do we need to do to be able to answer some of the questions we brought up today? Like, is it safe for me to exercise? Can I get a massage? You have no idea. Can I ride that roller coaster in Disney World? Like, can I travel? A lot of these questions come up. They're not silly at all. We love all of them. We're like, these are very reasonable. And a lot of the times we just have to say, listen, we don't know. This is probably what sounds reasonable, but that's another thing that we potentially need to study. So I am truly, truly grateful to be part of the iSCAD registry. iSCAD registry is really funded and really pivotal from the work from the SCAD Alliance, which I'll make sure I highlight today. It's our non-for-profit, really patient advocacy group, which you can obviously find online and in all social media. And they have been central in supporting this registry and supporting research and really allowing us to advance the science, not just here at Tampa General, but really at all the hearts. Next time I have to put the entire world, because there are sites outside of the US. We are inclusive. This is not exclusive in any way, inclusive of all women, of all investigators, of all patients and survivors, and of anyone who's really interesting in pushing this charge forward with us.
Well, thank you, Dr. Crousillat. And as I mentioned, we have just a lot of great comments that we're getting from people thanking you for your time. And Maresa, again, for you for being so brave to share your story. Dr. Crousillat, we might have to get you to work a little overtime to answer some of the questions that are still coming in through here.
I'd be happy to.
Thank you both so much for sharing such valuable information today. If you want to know more about the TGH Women's Heart Program, make sure to visit that web address that's on your screen or scan the QR code that will take you right there. We want to thank everybody for all their engagement, those who joined live and those who submitted fantastic questions ahead of time. We look forward to seeing you for our next Ask an Expert installment soon. Have a great rest of your day.